Hi, Dr. Wharton, can you hear me okay?
Yes, ma'am.
Okay, awesome. I just wanted to test drive the remote on your end, if you don't mind,
Okay.
to make sure it'll show, it should say remote control at the top one at the tool. Okay.
You want me to try to do something?
Okay, let me, okay, I think I'd give it to you. Oh, okay, perfect. Okay.
Oh, I see. Uh-huh.
Okay. Oh, perfect. Okay, awesome. So I can give
Got
it
it.
all without. Okay, perfect. Just wanted to test that out. Perfect.
Perfect. That works for me. Thank
Thank
you.
you. You're very welcome.
Hey, Jessica.
Yes. Uh-huh.
We can both use the mouse and sort of go through our own slides. Is that the plan?
Right, correct. Yes. I'm
Awesome.
sharing it from my screen, and then once your portion comes, I'll give you your remote control access, and yes, you'll be able to go through your slides.
Awesome. Thank you so much. Just
Of
clarifying.
course. Yes, you're welcome. Good morning. Can you hear me okay?
Yes.
Okay, great. Hi. Yes, so you will be first. So we were testing. I'm going to give you, we're just going to test it real quick. I'm going to give you your first. I'm going to give you remote control access. That way you can control your slides during your portion if you'd like to try it. Perfect. All right. Yes, perfect. Thank you so much. So you're good there. And I'll give it back to you at 12 o'clock. Thank you.
Mm-mm.
All right, good morning, everyone. The time is now 12 p.m. Thank you all so much for joining the ONR Research Roundtable with today's topic of new SON COVID-19 research and navigating the new normal. And we have our wonderful panelists available for you today. We have Dr. Lisa Thompson, Dr. Jennifer Frediani, Dr. Mik-Young Song, Dr. Kenneth Hepburn, and Dr. Whitney. And we will have Dr. Thompson off, and I will now provide you with access, Dr. Thompson.
Okay, sorry about that. I could not find my unmute button. And so I'm just going to start this off briefly talking about my work in kind of the global health context. And do I need to ask for the control of the mouse?
Yes,
No.
I have provided it for you.
Yes.
There you go.
Okay, so first of all, many of you know that I've been involved in this randomized control trial called the HAPPEN trial. This is a household air pollution and health study. It's a multi-country intervention trial. We're providing half of the 3,200 households that are enrolled with a gas stove and free gas fuel, which comes in tanks like propane tanks, along with the behavior change intervention to encourage the use of the gas stove. It's an 18-month randomized trial, and we're looking at many different outcomes. In the child, it's low birth weight, infant stunting at 12 months, and incidence of infant severe pneumonia. And we're also looking at older adult women and pregnant women's blood pressure. And this trial, at the time that the coronavirus hit, we already had the bulk of the women had delivered their infants. We had about 30 women in each country that still had to deliver. And I'm just going to talk about some of the issues related to the study. We already started to disenroll some study of.
Hey, Quinn, how are you? Yeah, it's still good. Let me just go like closer to my door. I get poor.
Thank you. Okay. So let me see if I can page down. Why is this not advancing? There we go. So what's the new error in the HAPPEN trial? My dog is barking. We had to go, we had 4 local IRBs in each country and the Emory IRB as well. And we had to answer to all of them about how our study would proceed. We also, of course, had different case rates in each country. Peru is currently, I think, the 4th highest country for coronavirus cases per capita, and India is right behind the United States, whereas the countries of Rwanda and Guatemala are very low on the ranking for case identification. So currently, we're not doing any research in Peru because of the suspension of activities that are not deemed essential. We've been able to resume in the other 3 countries to a limited degree. Cooking gas is an essential service. You can imagine if you can't cook, this is a problem, and most people use this type of liquid petroleum fuel that comes in tanks. So we were able to maintain the intervention throughout the study, which is great. We may not be able to collect health outcomes, but we're still providing gas to the intervention group. And I'm sure people have noticed that child pneumonia rates maybe not have not noticed, but since children are staying at home and not going to school, the pneumonia rates are very low globally, and that's great. That is one of our primary outcomes, but we did have some issues with children at home, sick, parents not bring their children to clinics to be evaluated, but that's kind of picked up a little bit in recent weeks. In the 3 countries we're able to monitor, some of the transportation has started up. We developed extensive standardized operating procedures in local languages, and we trained our field workers to implement them. So donning and doffing PPE, checking in the morning with our coronavirus symptom checker. And we go to the home, we use the Emory required set of COVID-19 screening questions. We get PPE for all of our staff and our participants in many of the different settings. As we all know, PPE was hard to come by, but we do have our staff wearing PPE when they make the home visits, and we provide masks to participants. And we implemented a COVID questionnaire, and this is really focusing on, did the family move? So maybe they're not, the intervention families are not with their stoves. And then kinds of hygiene practices, hand washing, which in some places with limited water is challenging, use of soap, isolation. Some of these houses are crowded, and we want to understand crowding activity. And then we're looking at how this has changed cooking practices and energy use, healthcare access, and food security. What we did as a process of evaluating these, developing these SOPs, is we started to look at each type of sample that we were collecting, and they're listed here, from buccal swabs, nasal swabs, dry blood spots, urine, and then other anthropometry, measuring the child length. So you can imagine you're trying to measure a child's length and they're screaming and they don't want you to do this to them. So we had to evaluate each of these procedures, and we developed a screening tool, which may be hard to read this, and I don't have a whole lot of time, but where we said, who is the participant? Where are we doing this procedure? How close do we get to the participant? How much time do we spend with that participant? What's the potential for aerosolization? And what kind of PPE do we need? So we evaluated each of the procedures, and here's a couple of examples. So we do lung ultrasound on a child. Where do we do it? How long does it take? And what will we need to wear to do that procedure? And the same for when we're measuring air pollution. How does that procedure? So this is actually led us to create kind of a level of risk from level 1 to level 4. Where we could assign, by definition and by example. And so we've written up a paper that we've submitted for publication using this risk tool. So it's under review. The second study is just briefly something I just got added to kind of a little bit at the last minute, but this is funded through Fogarty International, and it's through a Clean Cooking Implementation Science Network that I belong to. And this is not part of the HAPPEN trial. This is separate. And this is just looking at the impact of COVID-19 on household energy use in India. And this is working on this with assistant professor from Rollins, Ajay Pillarisetti. And this just kind of shows graphically the energy use, electricity demand before, and then during the lockdown, people were using less energy, and then it's kind of coming up. And this is just over a 29-week snapshot. But definitely, energy, the electricity demand went down. People weren't going to work. They were staying at home. And randomly selecting 600 participants who participated in a baseline survey before the lockdown, and using mobile phones. We're assessing different energy use patterns around cooking and lighting, and whether or not they're actually using their LPGs. I should say that India is one of the countries that's provided LPG widely, so it's kind of a success story for clean cooking. And this is my last slide here, just shows some of the preliminary findings, which this is presented at people who are obviously interested in clean cooking. So for this group, maybe not as interesting, but just looking at whether or not they were using solid fuels more or less or the same, or LPG more or less or the same. So this is just a very preliminary from the first survey, but this will be a longitudinal survey of 5 or 6 rounds over the next 18 months to see what happens with energy use during the coronavirus. So that's my talk. And now do I have to give mouse control to Jennifer?
Yes. I will provide it to Jennifer. I will take yours off. Thank you, Dr. Thompson. And Dr. Frediani, you have control right now. Just, there you go.
Okay. Oh, there it goes. Oh, and now I'm going too far. Okay, so I've been pulled into the RADX program here at Emory, which is the Rapid Acceleration of Diagnostics initiative. So this is an NIH initiative. And to give a little history, so for a few years now, there's been, and this is kind of a mouthful, but it's ACME, POCT is the acronym and how we pronounce it. But this has been a group on campus that has been developing diagnostic, little devices for other things. And they were asked to kind of pivot and provide this infrastructure for these COVID diagnostic devices. So that's kind of the history behind how we got involved. No, it's not advancing. There we go. Oh, too far. So a little bit of an overview. This is an NIH initiative that was put in place to speed up the innovation and development in the commercialization of all of these technologies. So basically we work with companies that have developed some kind of diagnostic test, and we do a lot of the BSL-3 verification, limit of detection verification in the lab cores, and then if they pass through all of those kind of checks and boxes, they come down to the clinical cores, which is where I am, and we provide human samples for them to test their devices at various sites. So it's there's many sites around the country, and the ones that I'm involved in here are the RADX Tech, which is the diagnostics, and then also the RADX Up, which is specifically for underserved populations. And we just got word yesterday, I think, that is getting funded. So that one is out of Rollins and looking at underserved populations with diabetes. So it's out of the diabetes center there. So I'm involved in that one too. I'm not sure how I'm gonna do both, but that's to come. And so this is just specifically for diagnostic testing. So we do have this infrastructure, and they're thinking that it could pivot into vaccine clinical trials as well, once those need to be ramped up quite a bit. But right now it's just all of these different companies with all of these different kinds of diagnostics. And this can range anywhere from an anterior nair, swab pregnancy test looking thing, where you take the swab in the nose and then you wait 20 minutes, and 2 lines means you're positive, 1 line you're negative. We have some breathalyzer type tests coming in, some smell tests. Name it. That's kind of the cool part about this project, is the innovation of the things that these companies are kind of coming up with. So they basically have a review criteria, and we treat these like a study section. So we have kind of 2 meetings a week, and one is to kind of talk about what's coming down the pike, and then the second meeting is usually a study section on the validation that we've already done, and we basically are deciding whether these companies get more money to ramp up manufacturing to get these out to the public. So this is kind of how it works, and this, all of these different ideas come in for a national call into NIH. The NIH actually does the first kind of phase, the phase 0, which is like they've described it as a Shark Tank like process. So basically they pitch, and if the NIH people think that, it could have some merit, then they go further into phase 1. If not, they're done. So phase 1 is kind of what we're doing now, and that's the validation, the limit of detection, and then some of the preliminary clinical tests. And then phase 2 is kind of a ramp up. So this would be like, instead of just getting 30 positives, 30 negatives, this would be like getting 500 specimens. So some of ours have moved on into work package 2, which is what we call that. And some haven't, so they haven't made it past that phase 1 phase. Some, we've denied because they were, just too expensive, and we didn't think that was a good thing to have out in the marketplace right now. Some were just too hard to use. Some just didn't work. So there's different reasons why we kind of reject some. So in May of 2020, Wilbur Lamb is the overall PI of this. He received a $31 million supplement to kind of do this test verification for the work package one, the phase 1 phase. We're basically testing the test, and that's kind of what we call ourselves. So it's a huge team, and it's really touches just about every section of Emory and Georgia Tech, and involves faculty like myself and physicians and nurses, coordinators, you name it, lab people. And so they, like I said before, they do the BSL-3 laboratories with live virus, since it's the first testing, and then they do their limit of detection at the Emory labs and children. So this is a collaboration with PEDS also. And then we prospectively collect these patient samples at various sites. And that's kind of where I come in. This is just overall, and I think this is actually old, but these are all the different cores that this RADx Acme POCT kind of has. And I'm in the clinical specimens core. And then we also have this clinical studies core, which is another supplement grant through UMass, where Emory is a site. And this is also just different tests, different companies that we're working with through this mechanism here. And you can see there are some TBDs. So I'm basically doing 3 jobs right now, but hopefully that will change soon. So the clinical studies core, which was that little box kind of off to the left, this is all work package 2, so phase 2 companies that are ready for that manufacturing scale up. And so they need bigger studies. They need, on the range of like 500 samples. And it's, like I said, at the head lead schools are at UMass and Lau. And this is a $5 million sub-award to provide infrastructure in this clinical studies core. And so we run sites at various places, and some are using existing COVID testing sites through Emory and Children's, and then some we're creating our own. One of the bridge kind of situations that we're using between RADx Tech and RADx Up is the Mexican consulate. So we're doing a lot of testing, big, Saturday testing events where we test 400 to 500 people out at the Mexican consulate. And so that will kind of bring us into the RADx Up grant as well. So we're organizing that. This is just the org chart right now for the clinical studies core. So these just show all of the different sites across adult and pediatric, and kind of just the sheer numbers that is taking to run all of this. And that's it.
Thank you so much.
I'm here.
Awesome. Thank you. Thank you so much. Let me take the control off, Dr. Hepburn. And I'll
Okay, well, go back to the
Yes.
lead slide, if you will.
Yes.
Sorry, everybody. I was the internet went out at home, so I dashed into the office, and here I am. Wanted to talk about very briefly about the project that a number of us are involved in, Carolyn Clevenger and Glenna Brewster and Fayron Epps and I, and faculty across Emory, on a project that's been sponsored by the Georgia Memory Net, our Alzheimer's Disease Research Center, and our own Roybal Center here. And that is a project for family members who are taking care of people living with dementia. We're calling it Navigating COVID-19, and the title we're giving it is Caregiving During Crisis. So our general metaphor is that dementia family caregivers are functioning like clinicians, in that they have to provide care, complicated care for people who are living with degenerative, progressive neurological disease, cognitive disease. And they need new skills, a separate set of skills for navigating the COVID-19. So Now, if you can go to the next slide.
Yes, you now have control, so you can,
Ooh, I have control.
yes, and there you go, perfect.
There. So, thanks. So we think that people who are in this role need three rather complicated sets of competencies for caregiving. One is to know how to manage a person living with dementia and guide his or her behavior, as well as take care of herself. Thinking about the caregiver as an instrument of the person's well-being, taking care of the instrument is paramount. And then to be able to maintain, establish and maintain a safe home. And so there need to be sub-competencies in the areas of infection control, managing the risks of leaving and re-entering the environment, either as a caregiver or with the person living with the illness. And then other threats to managing other people coming into the home, whether it's a plumber or a home health aide, thinking through the infection control issues involved there. And then really managing the threats to well-being in general. You do not want to bring the person to an emergency room, so how do you reduce the risk of falling? And finally, navigating the healthcare system. Acting on the healthcare stage, which I'll get to in a moment, and planning for the worst case. So what we've designed is an online course with the help of Emory Nursing Experience instructional design team. This is going to be something that people can access online, and it's going to be self-guided course. And pretty soon we're going to see if it works. So creating and maintaining a safe home, the bubble. There's a whole set of information on virus facts and frequently asked questions, basic control, infection control practices. I've already kind of gone through this. And also the threat of isolation, kind of being isolated, being sheltered in place for an extended period of time, longer days of caregiving. These are all threats to the well-being of the caregiver. We see the we've developed this metaphor of healthcare as a stage, where all the world's a stage. And the dementia caregiver is really the key person. So she has, or he has to both script the lines to use when encountering the healthcare system. So we're teaching SBAR, right? We're kind of giving people a rough idea of what the history and physical looks like so that they know how to present the case, as it were, to a clinician. So they have to learn how to learn their lines, write their lines, learn how to deliver them, understand who the other actors are and what their expectations are, and what the rules of engagement are within the healthcare setting. So all of this is being done in an online framework. We are 2 weeks away from a beta test of this. We've got some caregivers from the Integrated Memory Care Clinic who are going to be part of that group, and we'll reach out to others across Georgia for it. We just got the administrative supplement to the Roybal Center, so we're going to be able to take this national once we get it refined. Okay, that's 10 minutes. The dementia caregiving management is going to be a short course in the Savvy Caregiver program, which will be focused around skills and strategies for promoting engagement, meaningful engagement by the person in daily tasks and activities, which is the core of what we've been teaching people in Savvy Caregiver and Telesavvy for a number of years. So that's what we've been doing with in trying to address the COVID threat. I think that's it. Yeah. Mi-Kyung.
Okay, I'm here.
You are here, so is Una.
Yes, I'm sorry. I'm wearing my headset, but he's just started barking. But can you hear me okay?
We can hear both of you just fine.
Maybe he wants to present. Okay, so the title of the project that I'm going to briefly talking about is the impact of the COVID-19 pandemic on end-of-life decision-making among patients with complex multi-morbidity, and also their surrogate decision makers. Do I have control?
Yes, you have control. Just try it out and it will,
No.
go ahead. Yeah, it says waiting for you to control. There you go. Thank you.
I'm not seeing.
There you
Oh,
go.
there we go. Yes. So this R01 supplement was a response to research on the special interest notice, which is about the research on the 2019 novel coronavirus and the behavioral and social sciences. And this study will leverage the parent study, which is a pragmatic trial of an evidence-based advanced care planning intervention, so-called the SPIRIT intervention, that involves 39 dialysis centers across 4 states. So every part of the world has been affected by the COVID pandemic, and the pandemic has brought us fear and uncertainty to all aspects of life, and especially to medical care. And the research has shown that after experiencing a natural disaster, people exhibit more risk reverse behaviors, and that belief systems can change, understandably. And that is, people update their perception of a background risk and perceive the world to be a much riskier place. Oh, I wasn't advancing the slides. I'm sorry about that. So this, the scientific premise of this supplement study is based on the 2 bodies of literature. And the first one is, the studies have shown that the values and preferences for end-of-life care are stable over time, especially after individuals made an effort to actively think about their end-of-life preferences, such as advanced care planning. I'm not talking about just completing a living will or that kind of document, but more in-depth conversations. But at the same time, oops, let me go back. Another body of literature suggests that abrupt and disturbing social changes, such as disasters, can affect psychological mechanisms of underlying cognitive performance. So the effects of a disaster may bring doubt to clinicians and as well as families regarding how to interpret an advanced directive or end-of-life care preferences that were expressed sometime prior to the pandemic. And that there is very little evidence, empirical data to guide advanced care planning with our sickest patients in the setting of a disaster, and especially one that is so novel. So this study will, I expect to generate some new empirical data on the impact of the COVID-19 pandemic on patients' end-of-life preferences to address whether the stability of preferences is disrupted by the pandemic. So we anticipate that pre and post-pandemic changes in end-of-life preferences would be more prevalent in the control participants who did not receive the advanced care planning interventions. So let me show you briefly the study design. Okay, so this is a very simple study design, but hard to implement across 4 states. But this figure displays a simplified design of the parent study, and we have enrolled nearly 400 pairs of dialysis patients and their chosen surrogate decision makers. And a sizable number of diets completed baseline data collection in the SPIRIT session if they were from an intervention clinic, and then 2 weeks of follow-up before the outbreak. So we use the index date to be the March 13, 2020 as the index date. So in this new longitudinal cohort study, we are adding 2 more measures. So in this longitudinal cohort study, we will recruit 100 DIEs from the pool of those pairs who completed up to 2 weeks of follow-up before the index date, and have them repeat the study assessment battery 2 more times, along with the new COVID-19 stress scales. The ongoing multi-site clinical trial of an advanced care planning intervention offers us a natural experiment to explore the interaction between an evidence-based advanced care planning intervention and a large-scale disaster that could not be conducted otherwise. Thanks.
All right, thank you so much, Dr. Song and Dr. Warden. I will provide you with your access. There you go.
All right, thank you so much.
You're welcome.
So I was going to present on 2 studies that we have ongoing now, but I think I might just have time for one today. This first study is a COVID-19 serosurvey, a clinical in-person prospective study that was funded by the Dean's Rapid Response to COVID-19, the pilot award. And I first need to start off by saying that this study would absolutely not have been possible without the School of Nursing and the faculty and staff that really drove this study. So faculty including Brittany, Daniel, Irene, Val, Glenna Brewster, and both my lab and my colleague in medicine, Dr. Hu's staff. Everyone really was on board, and when I say this couldn't have taken place without them, it literally could not have happened without every single person on board for this testing. So we're very appreciative for the ongoing collaboration we have with all of these faculty members. So the purpose of the study is to test for to test a novel serology test for COVID-19 antibodies, and also test for inflammatory markers in asymptomatic community volunteers and individuals who we consider at high risk, including African Americans, first responders, and people that were at the time in close contact with individuals that might have been or definitely were exposed to COVID-19. We did this in-person study in April and May of this year. So there was 2 phases. The first phase was in April, and that took place at Emory. And the second phase, we partnered with the DeKalb County Fire and Rescue, and that took place in May. And importantly, this clinical study took place before, during the university shutdown, during the citywide shutdown, and before the peak in cases. So, we're really interested in people that were at risk, people that were, potentially exposed, and to be able to test our novel serology test in conjunction with inflammation. And then what we're going to do is test them a little bit later. So we tested 373 people over 6 days. And again, this was in 2 phases. So the first was an Emory study where we enrolled 300 individuals, and the second was at DeKalb County Fire and Rescue, and we enrolled 73 individuals. We did in-person testing. We did a blood test, and I'll go into that in a second, but we also administered red cap questionnaires in conjunction with other faculty from School of Nursing and School of Medicine with their input about questions and issues that they would want to know about concerning COVID. So Ursula Kelly, Arshad Kayumi, a number of investigators had, their own sort of questions they want to ask. So in addition to our blood tests where we're looking at biomarkers, we looked at indices like medication history, current and past symptoms that might or might not have been associated with COVID, demographics like, age, race, what you did for a living, if you were able to social distance, sleep, mood, depressive symptoms, and then importantly, knowledge, beliefs, and information sharing about COVID. So where are you getting your information? Are you watching news? Are you listening to politicians? Are you being compliant with social distancing, hand washing, mask wearing? If so, why? If not, why not? And then what do your sort of social networks think about all of this? Are they doing the same thing for you? Are they the same thing as you? Or are they doing something different? So these are just kind of sort of pictures of what we were doing. So our first publication we have out of this it's in preprint right now, and it's just kind of a how-to about if you were going to do a rapid seroserology test during a pandemic, when everything is shut down, what do you need to do, and what tools can we give other investigators, and what lessons have we learned in order for you to do this? So, we did this again in April and May, and all of the testing for Emory took place in the School of Medicine atrium, which is the top left picture. It's in the School of Medicine building. And we went through a lot of, a lot of different processes in order to find a place to do the testing. So, we had to find a place that was open, that had a working HVAC and janitorial, a place where they weren't doing active COVID testing, a place where we could do private consenting, and where we could sort of safely navigate the space. And that in and of itself was a really big deal. So this is kind of where we decided on. And in the bottom left picture, we have sort of the School of Medicine atrium. So these doors were locked, and I met each individual at the door when they were coming in, and each individual was scheduled. So we scheduled 4 participants per half hour in 1 hour blocks. And so we saw up to, I think our max was 80 participants in a day. So they were temperature checked, symptom checked. They came in this door. We had them sit at individual tables, which were sanitized between individuals coming in. And then when phlebotomy was ready, when consenting was ready, we escorted them into this picture, which is kind of consenting stations. So they went and they were consented by a member of the research team. And then after that, they were escorted to a sanitized phlebotomy station where our School of Nursing faculty rock stars were taking blood from a massive amount of people all day, every day for a lot of days. And this was at Emory, again, in the atrium. And then that was the first phase. And then the second phase, we went to DeKalb County Fire and Rescue because we have longstanding relationships with that community. And we've done past studies with them. So they were excited for us to come in. So we went in, viewed the space, make sure everything was appropriately socially distanced. And then in 2 days, we saw 73 people in that space. So that was firefighters, police officers, EMTs, and they went through kind of the same kind of thing. So we temperature check, symptom checklist, escorted everybody in. Everyone was individually or group consented. And then they went to a different station, which was manned by Dr. Kayumi's group, where we did some vascular tests. And then they went to the phlebotomy station, where School of Nursing faculty took their blood. We took about 40 mLs of blood. Some of that has been biobanked, and then the rest of it is used for the novel serology test, which has since been licensed. And also we're looking at inflammatory markers. And then top right is just us thanking our team in a really fun kind of last day when we were done doing all of the testing. So we took over the School of Medicine atrium, and so we decided to celebrate there. So as far as initial results go, you know, the primary serology tests are still kind of underway right now because all of this happened so quickly. But basically, I can tell you that in the 300 participant Emory cohort, we had about half the participants were healthcare workers. There was a large representation from emergency medicine, both at Emory, at Grady, and at other hospitals like the Shepherd Center. We planned on doing a lot of recruitment because we wanted this to happen so quickly, and we didn't have to recruit. So because this happened so quickly and everyone wanted to know what their risk was and if they had been exposed, we're just kind of traveled like wildfire. And so, you know, we were able to actively test 373 people, but again, we had a wait list of 300 individuals that we just didn't have the capacity to get to. Of the Emory cohort that we studied, half were women, 70% identified as non-Hispanic white. They were, as you would imagine, highly educated. Over 90% had an advanced degree, and over half reported having a known exposure to COVID-19, and also over half reported having symptoms that they thought might or might not be related to COVID, which primarily was coughing, congestion, and muscle aches. In the second cohort, in the DeKalb County cohort, 84% were male, 68% identified as non-Hispanic white, and their symptoms were a little bit different, which was 100% actually reported loss of taste, flu-like symptoms, and dizziness. So, why is this study different? We're testing again a novel antibody test, and we're really trying to use that in conjunction with what my colleague in medicine and I do, which is look at a inflammatory characterization. So everyone's probably heard of the cytokine storm. So we're really trying to use inflammatory markers in conjunction with a serology test in order to come up in addition to information about demographics like age, race, education, with a whole system sort of profile of what is a person's risk, and then if a person becomes exposed to the virus, what is your probability of recovery, and who needs to have treatment first, who might need to have a vaccine first. That's really kind of the premise of our study. And then next steps, in October or early November, we are going to invite back all 373 individuals for follow-up blood draw, serology testing, inflammatory testing, blood pressure. And then we also have submitted a number of additional funding mechanism applications, such as the RADx Up application to look at minority and underserved communities, because we're finding some really interesting results, which maybe I can share with you later. But I think as of now, I am out of time. So thank you very much. And I'll give it back to Jessica.
All right, thank you so much. And now we will open it up for questions to our audience.
Since we have the extra time, why don't we let Whitney talk about this last slide?
Yes. Of course.
Sure. Okay, sure. I'm happy to. So, so I have a whole bunch of more. So that was the first study that we did. I'm just going to go over this first one. The second one, we submitted a RADx Up application, which was mentioned earlier, and that is an application to address the barriers to COVID-19 testing and vaccines in underserved communities. And I've in my research and my colleagues' research and a number of, I mentioned the School of Nursing faculty, we're all interested in, what are both the tangible and the belief-based barriers to testing and vaccines and research participation, and how are we able to address those barriers, especially amidst, in the current climate where we have individuals, and especially individuals from African ancestry, Black individuals who are, we're mobilizing for, a social movement right now, necessarily so, but, we're not able to enroll the same individuals into studies, and there is major distrust as far as the, as far as the scientific community. And I think a lot of that is, distrust, it's misinformation, and all of that are just exacerbated right now. So, I've been talking to Kylie Smith a lot, and so she sent me this really cool, a really informative picture on the left. And that is a representation from 1938 of a security map, which talks about the financial risk based on neighborhood. If you were going to buy something in a neighborhood, whether it be a personal property, a business, these areas in red are denoted as high risk, and that is because that is where Black and brown people lived in 1938. This is called redlining. A lot of you are probably familiar with that. And then when we were making this grant that we submitted last week, I was just interested, and I said, okay, well, where do people live now? I live in Atlanta, so let's see what happens. So what we did was look at neighborhoods that are predominantly white and neighborhoods that are predominantly not white in Atlanta. So here you see the middle of Atlanta right here, and the blue is neighborhoods where people that are white predominantly live, and then the green is where people that are not white live. And then the third thing we did was overlay the most prominent COVID testing sites, which are all of these red dots. And this isn't all COVID testing sites, but this is the most visited. Also, these are mostly drive-through testing sites, which is a problem if you don't have a car. So as you can see, it pretty much, is a pretty stark, a pretty informative visualization about, the continuity between 1938 redlining and current availability, population-based neighborhoods, and resources that are available. And then, in a couple of other slides, which I probably don't have time to show you, we also overlaid food deserts, transportation maps, because transportation, especially MARTA and bus systems, have been significantly reduced. So, not only is it a problem to have a limited number of testing sites, but there is a problem in being able to get to those testing sites. So that's kind of the premise of the second wave of this, and the new application that we put in to be able to combat these tangible barriers, but then also understand what the ramifications of all of this misinformation, confusing information. I mean, it's confusing for me, right? And us as faculty and academicians, we're kind of living this every day and embedded in it. But, what do you do if you have mixed messages with something as simple and simplistic as hand washing and mask wearing? What does that do to the trust of the medical community, let alone if you're going to enroll in a study? So it's really no surprise to us that You know, the Moderna trial and everything is pretty much kind of come to a very slow, to a sludge because, you know, we don't have enough Black and brown people, you know, volunteering for these studies, but I wouldn't either, given, you know, past atrocities and what's kind of happening right now and the tools that are available to people. So
Right.
that's the premise, and that's the focus of these two graphics.
Cool. That is this stark graphic. That's terrific. Thank you. There's a question. Kelly, you have a question?
Hi, I'm Kelly Goskowitz. I'm a student in the DNP program, and recently I listened to Dr. Kylie Smith's presentation, and she had this slide and some others. And in reference to the COVID testing stations, maybe I missed this earlier, but is there any discussion about making mobile units available, similar to some of the stroke units that we have that are available, like such as Grady's, I think?
I have anybody got an answer to that?
Yeah, from the RADX side, we're in the process of trying to purchase an RV. Right now, we're using the mobile care unit that Children's has. And so when we go out to our community events, like the Mexican consulate, we have that. We don't bring the participants into the unit. It's mainly for to carry our supplies, to make sure the staff has a safe place to wash their hands and go to the bathroom and get some air conditioning, because they were using it over the summer. And I guess through the winter, it'll be a heat source. It provides a generator for some of the devices that we test require power. So yeah, we are utilizing mobile units, and with the RADX Up grant that we have, we plan on using that more in to go like outside federally qualified health centers, because that's what we've kind of tapped as the places that we're going to go do our diabetes testing.
Thank you.
Krista Irwin has a question about vouchers. Krista?
Hey, I was just wondering where you're doing recruiting for vulnerable populations, and whether you're like offering maybe transportation vouchers or MARN cards.
That's a great question. I can say that at Emory, what you get is valet parking, but you got to get there if you're taking public transportation. I'm not sure if they're giving vouchers. It's a really terrific question.
We had studies. Oh, go ahead, Whitney. Sorry.
No, I'm sorry. So one thing we're trying to do is identify, you know, it's kind of going off the food desert thing. So the food desert model. So one thing we're doing in this new project is, you know, tracking 300 people with whom we already have relationships, but asking them to have 6 or 7 people to make a massive sort of social network, which doesn't have to utilize gatekeepers, but utilizes people's personal social networks. And then people are doing activity tracking, and we're tracking on phones. Of course, this is, you know, voluntary, but, you know, we want to know where you go. We want to know where you don't go. And if you don't go there, why don't you go there? You know, do you want to go there and not go there? Or are you going to specific, you know, grocery stores? If you're going to get testing, do you prefer, you know, being tested at a library, at a church, at a clinic? Where do you feel most comfortable, and where can we really go in? You know, the mobile testing site, I think has been helpful for some places, and we look for that when, you know, we finally, after the 11th place, found the you know, the School of Medicine atrium, but we looked into that. Then you know, we're also, you come into, you know, people standing, you know, you want to like regulate how close people are standing in line and making sure everyone is safe. And then, you know, you don't want people standing out in the rain. And because we did this in April and May, it was just too hot. So, you know, we have to take temperature into play, but we're also thinking about doing this in conjunction with polling places. So please vote. If you don't want, you know, if you're going to be voting, you know, maybe stop by and get a serology test for free. And, you know, we want to know where all of those places are too. But, you know, unfortunately, those have been taken away. as well. So, but we're trying to think outside of the box. And if anyone has any ideas, throw them at us. Like, we're kind of working off the cuff here. So whatever you think, please join our team.
Hey everybody, this is Drenna. Can y'all hear me?
Yeah.
So I still have no power, and I've just tried to master Zoom on my phone, and I've heard that I'm drawing on your screen. I apologize. I don't know how to get it off. It's been one of those days. 2020 never disappoints. Thank you very much for hosting and you guys for presenting. I'm so sorry I wasn't able to lead this.
Jennifer, I thought you had something you were going to say a bit ago too about.
I just was going to say that we are kind of tracking this also. One of the aims in the RADx Up grant that we have is to kind of do a similar thing where we're approaching people and asking them how they would like to be tested. You know, would they like a home visit? Would they like a mobile unit? Would they like to go to a testing site? So that is part of our grant as well. It just happens to be in a diabetes population instead of so underserved diabetes population.
You know, I wanted to add one thing about the study that we're doing, the online study. In doing it, we've really understood that there are major gaps. We think, oh, online, and we can make this available to lots and lots of people, but that's not true. If you look at the map of Georgia, the internet access is terrible, particularly in the Southwest. And not everybody has internet anyhow. So we have begun to partner with the Gerontology Center at the University of Georgia, which has a link to the statewide cooperative extension service, something that our researchers in the school ought to think about. Because they have an office in every one of the counties, and they have excellent Wi-Fi to those offices, and also they have a local credibility and presence. So this is like, we're just getting involved with them, and I'll be able to report back in a year whether there's any utility to this. But I think when we begin to think about how do we reach people with information, then we have to think beyond the internet, because it doesn't reach everybody. And not everybody has access. And this might be one vehicle for it.
This is Sandy. I just wanted to jump in and with a comment and a question. This is great, and I really appreciate all the speakers. It's wonderful to see how quickly you pivoted to adding COVID-related questions or creating a COVID-related study to a new study. So one of the things that I've noticed is that so many of the calls, and I guess this is my question moving to funding, so many of the calls are attached to other grants. So you have to have a grant to get the grant, the supplement, or the administrative supplement. And I'm just thinking about, you know, there are so many questions arising around long-term effects of COVID and the pandemic. And, you know, whether there are any thoughts or recommendations about seeking funding, you know, through either just the open mechanisms, like just the COVID-related R01, you know, how do we think those are going to be reviewed? And then are there other special calls coming? Somebody in our cluster group mentioned earlier that some of the COVID-related open calls are now closed because they've received so many proposals. So just where do you think that kind of funding might take place for de novo studies in the future?
I'm on a NIH study section for R21s through the NIEHS, and that is looking at these kind of short-term, rapid policy environmental shifts, and one of them is looking at COVID, and that's specifically for de novo studies, not ongoing RCTs or things like that. So there's been it's been very interesting to see the submissions that come in through that. A lot around air pollution, but some around water quality and things like that. But it is environmental studies for the most part.
Sandy, I think that there would be a lot of opportunities in the future without having to have a COVID-19 specific calls.
Yeah.
That is, once we have some preliminary data related to this, there'll be a lot of applicable calls really, as part of, could be, it would become part of a chronic condition resulted from COVID-19 infection. And also there are some calls related to disasters. And those are not the areas that we actively participate, but there are calls out there. But I think it's a matter of time once we start getting some preliminary data related to COVID-19.
I think that's just a wonderful question. And my feeling is that we better think in a post-COVID way about applications, that at the earliest, we're going to get stuff in February, right? And it's not going to be reviewed until June. So the researcher's imagination ought to be projecting out to a project that might start October of 2021. And what is that world going to look like? And how do we use the data we've got now and the framework that we've been applying to this essentially a year into the future? Because I think the COVID passion at NIH will wane, and so I think being ahead of that will be really important for our applications. But I think the parent application vehicle is still just fine.
Thank you.
Yeah, great question. Well, I think we have reached the limit of time. All of the cookies have been eaten, and the sweet tea has been consumed. So thank you to everybody. I'm standing in here for Drenna, and thanks, Jessica, for engineering this and for emceeing it while we were started. But I wish everybody, thanks to all the speakers, and everybody have a good and safe day. So bye now.
Thank you.
Thank you. Thanks again.